Good morning. Today we are going to discuss about the mouth preparation in RPD. Non-prosthetic mouth preparation is done to prepare an unwanted oral structure that interfere with the placement of the prosthesis. Basically, cast partial denture is given in a very selected patient where few teeth are need to be replaced. Where prosthetic mouth preparation is done to modify the existing structure to further enhance the placement of the denture and the removal of the denture. That is, the path of insertion and the removal has to be parallel to each other. Objective of this mouth preparation are the direct stress along the long axis. The abutment should bear the maximum. As we all know that the cast partial denture is a tissue and the tooth-borne denture. So the direct retainer will take the maximum load, the abutment, that is abutment teeth, and the stresses which are generated should be well tolerated by the abutment teeth, which is possible only when they are directed on the long axis of the tooth, and also to eliminate the interference by recountering the teeth. Means the teeth which are present in the mouth has to be parallel to each other so that the prosthesis will not have any hindrance while going to the place and coming out of the place. So that is called the interference elimination. Create a retention by simple alteration procedure. This is once again concerned with the direct retainer, where direct retainer assembly should generate maximum retention with a minimum stress on the abutment teeth. So it can be created by creating a positive retentive area on the abutment teeth, or where the direct retainer or what we call as a clasp assembly is placed. Allow the placement and removal of the prosthesis without transmitting the wedging type of the stresses against the teeth which are in contact. Okay. The sequence of the mouth preparation, the procedure, how it is carried on, the sequence of the preparation are: first we have to relieve the pain and the infection. For soft tissue, whether a hard tissue, pain and the infection has to be taken care. Then the surgical procedures should be carried out, like if any root stump is there or the teeth which are very hopeless in condition needs to be removed, and any soft tissue or a hard tissue injury or the infection is there, that needs to be treated first surgically. Then the remaining soft tissue needs conditioning of the abused and irritated tissue, that needs to be taken care. After that, periodontal therapy or periodontal treatment is carried out, where periodontal treatment is done to enhance the support and the strength of the remaining teeth. Then you need to correct the occlusal plane. The plane of the occlusion, because of the long-standing the lack of antagonist teeth, or because of the stress, the teeth will be supererupted and the occlusal plane will be disturbed. So before we make any progress in the treatment modality, the occlusal plane needs to be corrected and brought to an optimal level, so that the teeth will have a coordinating occlusal plane. After that, if any ortho correction are required, so that the teeth are good but in a strategic position, but they are little inclined here and there, which needs a minor ortho intervention, so that it can be a very strategic teeth, so that for the success of the treatment modality, such teeth needs to be corrected with the orthodontic treatment. After that, if one or more teeth need to be splinted, for which has got a bone support or which have got a periodontal weak teeth needs to be splinted, that should be carried out. And after that, the reshaping of the teeth, so that the plane of the path of insertion, the removal will become parallel to each other. Then the preparation of the rest and the rest seat. Here the rest and the rest seat are the one which will confirm the proper seating of the prosthesis. So this needs to be prepared on the abutment teeth and where the direct retainer assembly is going to be placed. This is what is explained in the photograph. soft tissue management, where the flabby tissue is removed and healing is advanced. The lingual frenectomy, where the frenum of lingual frenum was very active, that is surgically removed and frenectomy is carried out. Okay, here the classification of the abutment teeth is discussed. One, the subject of the abutment preparation may be grouped as follows. That is, the total abutment teeth can be classified. Those abutment that require only the minor modification, means just occlusal plane reduction or maybe a positive retentive area and all, that they are called as a class 1 or a category 1. Those needs to have a restoration, like any other caries part is there, that needs to be removed and refilled. That is the second category. Those who needs those abut teeth which needs the maximum correction with a root canal treatment followed by the crown, they are the third category or grade 3. This one, the sequence of the abutment teeth preparation that require only in the minor modifications, like a preparation of the guiding planes, modification of the height of the contour, and the preparation of the retentive undercut as I discussed, and rest and seat preparation. Okay. And after that, the guide plane preparation means making the proximal surface of the abutment teeth parallel to each other. That's all. The advantage of guide plane, the guide surface and the guide plane are the foot impaction is prevented, because if the guide plane is not parallel, the minor connector of the clasp assembly will stay away from the guiding plane, so that in that triangular area the foot impaction can be there. So that needs to be avoided by giving a parallel plane to which the guiding plane, whatever we call, or the minor connector will have a proper adaptation and there won't be any foot lodgement. The hypertrophy of the soft tissue in that area is avoided if the prosthesis of the minor connector will have a perfect contact with the guiding plane. The friction force in these areas support the retention and stability of the prosthesis is a great proportion. The controlling the movement of the teeth by support of the anterior posterior direction is once again the guiding plane job, which needs to be corrected. Abutment teeth adjacent to the tooth supported segment. Okay, this is the guiding plane should be at least half to 1/3 of the axial height of the tooth. Use the light sweeping stroke. How it is done means a slight sweeping stroke, means it is not done very abruptly or forcefully. Just a mild correction is required to gain this kind of plane. The preparation, the position in which the handpiece must be held to prepare the required guided surface, so that they are all parallel to each other, and the path of insertion should be established on the study cast. You can see here the second molar, which is used as an distal most abutment, which has got a little inclined mesially, which needs the guiding plane correction, which is done in the cast and in the patient's mouth later, so that you will have a parallel teeth or a parallel abutment. You can see in the second or third picture where the guiding plane is parallel to each other, or because of the excessive correction, a crown is most suitable here. You can see in the picture. Okay. A cylindrical diamond or carbide bar this is the operatory details. Modification of the height of the contour. Height of the contour is nothing but where the maximum bulge of the point where a line is passing on the maximum bulge area. Enameloplasty to change the height of the contour is performed to provide an ideal placement of the clasp arm and to remove the interference and for the placement of the major connector. Okay. Rest is that component of the cast partial denture which will confirm the proper or the perfect seating of the cast partial denture, and which will prevent the gingival or the downward movement of the prosthesis. The component of the removable partial denture that transfer the forces down the long axis of the abutment teeth are called as a rest. The classifications of the rest are based on the relation to the rest and the direct retainer, based on the location of the rest, and based on the shape of the and the structure of the rest. You can see in the picture where it is related with the direct retainer, where it is related with the abutment teeth, where it is related with the design or the shape of the and the structure. The function of the rest are it support it prevent, as I told you, it prevent the downward movement of the prosthesis in the oral cavity towards the tissue. That is that. And second is the force transfer. Force transfer means it will direct the forces of the mastication or the eating forces parallel to the long axis of the abutment tooth. It act as a stop. The further movement of the prosthesis is prevented towards the tissue world, so that the soft tissue injury in the denture base area is avoided. To maintain the clasp assembly, if the minor connector and the clasp assembly has got one is a retentive arm, the reciprocal arm, the rest, and the minor connector. The rest will dictate, other than the minor connector, the shape and the action of the direct retainer. The maintain the clasp, which is usually attached to the occlusal rest, is properly surveyed and positioned. The function is as an indirect retainer in a free end denture base. This is what is shown here. The tissue stopper here, and this is a retentive arm. You can see here. Preparation of the rest. This is the one which is inclined towards the center of the teeth, and it is more than 90 degree, and the shape is almost more than one half of the buccolingual and the 1/3 of the mesiodistal width of the teeth. The groove must be carried out slightly over the labial surface to prevent the facial tipping. You can see here in the anterior teeth. In total, the mouth preparation includes, first, as I told you, the infection and the inflammation has to be taken care. After that, the surgical one. After that, the perio. After that, the any orthodontic correction, and after that, the reshaping of the occlusal plane. After that, the shaping of the abutment teeth and the remaining teeth, so that it will have a proper guiding the path of insertion and the removal. These things are in a total, as a treatment modality, are called the mouth preparation in RPD. The RPD mouth preparation will contribute to the success of the prosthesis treatment, because before we give a definitive prosthesis, the tissue and the remaining teeth are taken care, so that it receives a prosthesis which will work in coordination with the remaining structures, which will not damage the remaining structure. That is the main motto of the prosthesis or the prosthodontic treatment modality. As it is rightly said, it is meticulous replacement, and it is always better to preserve what remains in the oral cavity than the meticulous preservation or replacement. The more significant aspect of the treatment with the removable partial denture is careful planning and the execution of the mouth preparation and their accurate reproduction through the fabrication process. The properly balanced and the distributed force can contribute to an enhanced longevity of the both remaining oral structure and the restoration. Means the better oral preparation or oral treatment or the surgical treatment, whatever it is, carried out before the prosthesis is fabricated, the treatment will have a better prognosis, will serve for a longer period, and the patient will have comfort in using the prosthesis for a longer period, without causing any damage to the oral structure which are remaining. This is the fundamental of the mouth preparation in the RPD, which are taken care and which are carried out before any prosthesis or prosthodontic treatment. Okay, thank you. Have a good night.